Welcome to Week 3, Module 6. Organizational behavior is extremely important in healthcare systems today, and it really combines leadership, management, and having a good understanding of the healthcare system, people, process, and technologies. Our learning objectives: define and list organizational behavior situations involving culture and climate, workflow, and continuous quality improvement. So let's start with culture and climate. Culture helps define the underlying reasons and mechanisms for why certain things occur in an organization based on fundamental ideologies, assumptions, values, and artifacts. And climate is what the organization is like in terms of practices, policies, procedures, and routines. So if we're looking at healthcare systems, a community hospital may have a very different climate than, we'll say, an academic medical center where you have a research university function with education and research, along with clinical and possibly community missions. Other industries within healthcare, like payers or insurance companies, are much more financially based, sometimes very rigid, and so their climate may be very different from, we'll say, a startup biotech company, and that could be because of regulations that must be followed in a payer organization versus a startup. And some of the items that we really need to look at when it comes to culture and climate would be what is considered hot out in the industry right now. Burnout. There's an overwhelming amount of evidence in the literature right now about burnout. A lot of the evidence is around burnout of clinical staff, especially physicians, but it's important as informatics professionals to understand this situation. You could just go out and do a Google search and find a lot of information. There's some really good videos out there from ZDogg MD about burnout for physicians due to electronic health records. So sometimes good things that we put in from an informatics perspective can cause burnout. Psychological safety. We really want to have organizations that have psychological safety where employees and patients, caretakers can speak up and feel like they're being heard and not judged, and not have any implications from bias. That doesn't always happen. Patient safety. There's always a huge push in healthcare organizations to be aware of patient safety, not just from the typical clinical perspective, like making sure that a patient isn't given the wrong medication or given the wrong operation or surgery, but also that patients are safe, they don't fall if they're getting out of bed. Recently, there's been the Me Too, or the hashtag MeToo movement, with some harassment and discrimination, especially around gender, ethnic, and racial discrimination within healthcare. There's also the current hashtag Stay in Our Lane movement between gun activists and the physicians that treat victims of gun violence. There's mistreatment, especially in academic medical centers. And a lot of times this comes from the hierarchy in a healthcare system, where some folks, many times they may be clinicians that are highly paid specialists that may do what we call specialty bashing, where a surgeon may bash a community and family practice physician, or within the hierarchy, a physician may mistreat a nurse may mistreat a resident may mistreat a medical student. Also, the climate should be one of a learning organization and one that's focused on teamwork. Um, Healthcare is no longer about just a doctor and patient relationship, but also the care is provided by an entire team um, with all sorts of health science professionals. Workflow is important. It's important to understand that different functions within a health system have different workflows. The emergency department, they're trying to get people in and looked at quickly, and if they need to be admitted quickly. Outpatient clinics, where there may be, a lot of people sitting in a waiting room. Inpatient hospital stays, where patients may need to be moved from place to place for different testing. There's also other activities that happen within an inpatient hospital stay, within their encounter. Um, Having blood work done, or visits from the nurse, or environmental services to change bedding. Diagnostic testing, whether that's happening inpatient for those patients or on an outpatient basis. And lab processing lab work, not just for patients, but also anyone involved in a clinical trial or a research study. In academic medical center settings, there's also a research component and an education component. So you may have students, such as medical students or nursing or pharmacy students, as well as trainees, such as medical residents, in the workflow, having an educational interaction during that bedside communication with a patient. Continuous quality improvement, otherwise known as CQI. These are short-term project cycles to improve a process for a better output, outcome, and impact. These typically follow a quality methodology or framework. Some examples here: Six Sigma DMAIC. Six Sigma is to define, measure, analyze, improve, and control. There's also Six Sigma Lean, looking at just the value-added steps in a process, and also the PDCA, Plan, Do, Check, Act, sometimes known as Plan, Study, Check, Act, where folks will look to make sure they're defining the right problem, test out some potential solutions, monitor those to make sure that they're working, and then that cycle continues. So health systems, climate, and culture. Some questions to ask yourself when you are about to embark on some type of health information technology implementation. Is there solid leadership in the organization, or is there rapid turnover? Is there strategic planning that involves stakeholders from across the organization? Is there an annual employee survey? And what are the results? Are employees satisfied? Are there committees in place for improvements based on employee feedback? Are employees proud to be part of the team? Are there any internal politics, turf wars, or personality issues to be aware of? Do employees feel safe reporting ethical or safety concerns? And is there a system for reporting mistreatment or ethical concerns? Health IT and health system operations. It's important to make sure that you understand what that current climate is. Does the information technology function partner with the business? Or does IT dictate or overrule IT purchasing decisions? Is there a shared IT governance model in place? Are there monthly meetings where folks on the business side, the clinical side, and the IT side all come together and look at new proposed projects, new requests for different types of software, talk through them, do some type of risk assessment, and vet those out and make a decision together? Does IT understand the pain points from clinical, administrative, research, community, and education functions? For CQI, does the organization see the value in being a learning organization? Are failures treated as opportunities or threats? if we look at some type of adverse event, no matter how bad it is, even if it involves patient death, is that failure treated as a learning opportunity, or is it only treated as a threat? We'll fire the frontline person who failed to look at the medical record, or is the entire process looked at as a continuous quality improvement effort? Is there buy-in from leadership for dedicated time for rapid improvement events? These CQI initiatives take time. Many times a rapid improvement event will be a week-long event requiring folks from different parts of the health system to step away from their typical positions, whether it's clinical, administrative, or IT, and take part in this team effort. If there isn't buy-in from leadership to allow for that dedicated time, then we would be risking the success of the quality initiative. And our success is celebrated across the institution. So how does this all impact an HIT implementation? All of the things that we talked about today can impact the budget. Many of these HIT implementations are extremely expensive. In some cases, it could be $100 million to put in a new EMR. The timeline. Many of these projects are 6, 9, 12, 18 months in length. And, there needs to be a commitment for timeline. Quality. If there are any issues that could impact the overall quality of the implementation. Communication has to be good. There has to be adequate resources. And many times other projects need to be reprioritized based off of shared governance. And I would say the number one factor for successful HIT implementation is that there needs to be trust. There needs to be trust from everyone involved. And that goes from, the frontline worker, whether they're clinical, IT, or administrative, all the way up to executive leadership. So in summary, implementing health information technology requires that there be trust between all parties, collaboration. You can't really have people who don't want to come to the meetings, so they sit at their desk and they dial in. Many times it's important to have those face-to-face meetings. There has to be good communication. People shouldn't be finding out about things by accident. And shared governance. And this starts with leadership and strategic planning. There should be a vision, mission, goals, and metrics to make sure that everybody is meeting those realistic goals. So for next week, we have week 4, module 7. You may proceed to week 4, module 7 after completing week 3 Canvas assignments.